Bismillah ar-Rahman ar-Rahim. Again, it gives us a great honor to meet in another PICU activity that are focused currently for the COVID. And today we have with us Dr. Salma, who will be presenting about the pediatric multi-inflammatory syndrome. Okay. And if you have any questions, please you can share them in the chat. Meanwhile, please let's keep our mics and cameras in use. Okay, تفضل.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. Today we are going to share the knowledge about a new disease entity which is emerging. We are going to talk about the pediatric multisystem inflammation syndrome. It is a syndrome which newly reported. The case reported start last April, and there were a lot of mystery about this syndrome, whether it is a Kawasaki-like disease, it is a new disease entity. So people are starting to explore. And today we are going to share the knowledge together. The Royal College of Pediatric and Child Health developed a case definition for this pediatric inflammatory multisystem syndrome temporarily associated with the SARS-CoV-2 infection. And they adopted the following criteria for the case definition. A child who is presenting with persistent fever, signs of inflammation such as neutropenia, high CRP, and lymphopenia, with evidence of a single or multi-organ dysfunction, such as shock, cardiac, respiratory, renal, GI, or neurological disorder, with some additional features. And some features might overlap with the criteria for Kawasaki disease. Exclusion of any other microbial cause should be there, including bacterial sepsis, staph or strep shock syndromes, infections associated with myocarditis, such as enteroviruses. Because all of us, we know that any sepsis or septic shock can be associated with hyperinflammation, and then it might lead to multi-organ failure. And then the child who is involved in this syndrome might have the SARS-CoV-2. PCR testing might be positive or negative. So these are the criteria. This is the Royal College of Pediatric Child Health definition. And the mainstay, when they explore the case series, they have reported the commonest feature was that the patient will present with a fever together with some GI upset symptoms and then another symptoms. We are going to move to another case definition. There is the CDC definition, and they have a different name for this syndrome. They name it the MISC, which stands for Multisystem Inflammatory Syndrome in Children. Here, the criteria that the individual age should be below 21 years, presenting with fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization with multisystem, more than 2 organs involvement, cardiac, renal, respiratory, hematological, GI, dermatological, or neurological. No alternative diagnosis, which is similar to the criteria of the Royal College of Pediatric and Child Health. You should exclude other causative organisms. And the patient should be positive for recent SARS-CoV-2 infection by the real-time PCR serology or antigen test, or had the COVID-19 exposure within the 4 weeks prior to the onset of symptoms. And then the last definition is the WHO case definition. The criteria for the WHO case definition include children and adolescents aged between 0 to 19 years with fever for more than 3 days, and 2 of the following criteria: rash, conjunctivitis, mucocutaneous inflammation signs, oral, hands, or feet, hypotension or shock, features of myocardial dysfunction like pericarditis, valvulitis, coronary abnormalities, including echo findings, or high troponin or NT-proBNP, together with the evidence of coagulopathy detected by the checking the PT, PTT, and D-dimers. Acute GI problems such as diarrhea, vomiting, or abdominal pain. and elevated markers of inflammation such as ESR, C-reactive protein, or procalcitonin. And no other obvious microbial cause of inflammation, including bacterial sepsis, staph or strep shock syndrome, and evidence of COVID-19, real-time PCR antigen test, or serology positive, or a likely contact with a patient with COVID-19. So if you look at all the case definitions, as we mentioned earlier, they share that the age, of course, most of them below 21 or below 19 years of age, and all the patients should have the fever. Fever is a constant feature of the syndrome. And then together with the, as we mentioned, some features which shared with the Kawasaki syndrome and some GI upset together with the multi-organ dysfunction, and in addition to the markers of acute inflammation. So what is the evidence that such a syndrome exists? The first case series to describe this cluster of children was published on May 7, 2020 in The Lancet by Rafadin et al. The initial report of the multisystem inflammatory syndrome emerged from the UK in April 2020. Exactly, it was 27th of April when they reported the first cases in UK. Subsequently, an observational cohort study of children in Italy was published on May 13, showing a 30-fold increase in incidence of Kawasaki disease during the SARS-CoV-2 pandemic. Interestingly, they highlighted a higher rate of cardiac involvement and features of inflammation, like the macrophage activation syndrome. And we know that once you have hyperinflammation, the MAS syndrome will be activated, and then the child will develop the multi-organ dysfunction. And then also France started to describe a cluster of cases, 17 cases within 2 weeks, presenting in a similar manner. And cluster of children with similar presentation have been reported by news outlets in the United States and Spain. Abdominal pain, vomiting, and diarrhea have been the predominant early features in all cohorts, as we mentioned earlier. The GI upset together with the fever is the commonest presenting symptoms. A higher rate of Kawasaki disease in Afro-Caribbean children in the UK has also been shown in previous reports. Also in one of London Children's Hospital, they managed more than 20 cases with this Kawasaki-like disease. The majority have been tested for SARS-CoV-2 serology and have been found positive. And this is the same as in the French cohort, where 88 of the patients, they were positive for the SARS-CoV-2 antibodies, which means that they have the previous infection, and after a time, then they start to show the manifestations of the syndrome. That's why when they tested them, they have the antibodies. This is this report, this table, I get it from the European CDC. They published a risk assessment report. They gathered all the cases which were reported all over the world, and then they put by the country, date of reporting, number of reported case, the median age, and then the status of the SARS testing and other associated pathogens, the manifestations, and the case fatality, that is the mortality. So in Australia, in 29th of April, they reported 1 case. In Canada, they reported 12 cases. And then the median age in Australia was 11 years. And then patients were COVID-19 positive by PCR before deterioration of symptoms and positive IgG 2 weeks later. Other associated pathogens was group A, streptococci. And the clinical manifestation were hyperinflammatory state with abdominal symptoms, high fever, circulatory shock, DIC, and high inflammatory markers. In Canada, they reported around 12, and then it was on the 3rd of May. And then the status of the SARS-CoV-2 infection was not specified, and other pathogens were not specified also. And the clinical manifestations were atypical for the Kawasaki. That's to say, it shared some features with the Kawasaki, but not the full-blown pictures. In France, the number was a little bit higher. They have seen that areas which were hit hardly with the virus of the SARS-CoV-2 causing COVID-19 disease, they reported higher number of cases, such as Italy, France, UK, and US. So in France, the total number of reported cases was 125, and the age between 1 and 15 years, and 65 were positive by PCR serology, and 19 possible link with COVID, and 29 pending results, and 16 with unknown status. And then again, the presenting symptoms were Kawasaki-like or hyperinflammatory status. Germany reported around 5 cases. Greece reported 1 case. And in Italy, they reported 10 cases. 8 of them were positive by serology, and 1 was tested after a high dose of IVIG. So the test was inconclusive. In Luxembourg, they reported 5 cases presenting with atypical Kawasaki. In Portugal, 1 case. Spain reported 22 cases. 71% were positive by real-time PCR serology test for SARS-CoV-2. Sweden reported 3 cases. Switzerland also reported 3 cases. In UK, initially on 27th of April, they did not specify the number of cases or the SARS-CoV-2 status of serology or PCR test. But the presenting symptoms were signs of circulatory shock and hyperinflammation with features consistent with toxic shock syndrome or Kawasaki. And we know that there is some overlap between the two disease entities. Then with time, UK cases start to increase. They reported by the 6th of May, 8 cases. 3 were negative, and 3 negative, but with possible exposure, and 2 cases were confirmed with the SARS-CoV-2 infection. And then by the 8th of May, the number of cases in UK jumped to 40, with 12 over 37 PCR positive, and 7 over 20 IgG positive, and 54% have evidence of SARS-CoV-2 infection. So the overall from all this data, we can see that there is increase in number of reported cases with this pediatric inflammatory syndrome related to the SARS-CoV-2 infection. And then in US, 7th of April, 1 case was reported. And this 1 case, the age was 6 months. And then the patient, when tested for the SARS-CoV-2 infection, was positive. And the clinical manifestation was fever, erythematous rash, with sinus tachycardia, tachypnea, and irritability. And then in New York State, by 10th of May, the total number of cases were 85. And these 85, their age between 2 and 15 years. Proportion tested, a proportion only tested positive for COVID-19. And other pathogens were not specified, and clinical manifestation were not specified. So why they said Kawasaki-like syndrome? Many children with multi-inflammatory syndrome meet criteria for complete or incomplete Kawasaki disease. However, the epidemiology differ from that of classical Kawasaki. Most of children with pediatric multisystem inflammatory syndrome, they are older in age and adolescents who were previously healthy. Black and Hispanic children may be disproportionately affected. By contrast, classical Kawasaki typically affect infants and young children and has higher incidence in East Asia and in children of Asian descent. But we know that we have atypical Kawasaki, which can occur in an atypical age group, and it can also have an atypical features. The epidemiology of the MIS-C differ from that of acute COVID-19 illness in children, which tend to be more severe in infants, less than 1 year of age, and children with underlying health problems. So now from the evidence, we have seen that this disease is emerging. And then once we are already have an index of suspicion for a clinical case, then we have to send the labs. We have to investigate our patient. What labs we have to do? We have to do full blood counts. We have to do renal function, LFT, lactate, lactate, and then we have to do the coagulation profile because they will have a DIC-like picture. We have to send the triglyceride, ferritin, proBNP, troponin, because we have to detect if there is evidence of myocardial injury. And we have to send also the PCRs, ASO, vitamin D amylase, and then of course we have to send for SARS-CoV-2 serology. And then what we are expecting abnormal findings when we send the labs. Then some findings will be applied to all of the patients, and some findings will be applied only to some proportion of patients. So all of patients, they will have abnormal fibrinogen, and then absence of potential causative organism other than the SARS-CoV-2, high CRP, high D-dimer, and high ferritin. And the CRP tend to be very, very high. They will have hypoalbuminemia, lymphopenia, neutrophilia in most normal neutrophils. In some of the cases, you might have acute kidney injury, anemia, coagulopathy, and then high interleukin-10 if it is available, because we know that it is not available in all the hospitals, and then high interleukin-6 if available. Although when they studied the immune response, they found that in the COVID-19, the adult population tend to have a higher interleukin-6 compared to the pediatric. In the pediatric population, the immune system response, they will have a high T cell rather than the interleukin-6. Neutrophilia, proteinuria, raised CK, raised LDH, and triglycerides, raised troponin, thrombocytopenia, and high transaminase. These are the laboratory findings in the typical cases. And then again, just to wrap the information, so we said the definition that the patient will have fever, inflammation, single or multiple organ failures, and we will exclude any other microbial organism as a causative, as a cause for the presenting symptoms for the patient. And then the SARS-CoV-2 status will be either positive or negative with some additional features. And then all patients will have fever more than 38.5, and some of them, they will have increased oxygen requirement and hypotension. And then if we start from the head and going down, then the patient will have headache, confusions, can have conjunctivitis, lymphadenopathy, cough, sore throats. They can have also syncope, and then some respiratory symptoms, mild to severe. They might need mechanical ventilation. GI upset, as we mentioned, vomiting, abdominal pain, diarrhea. They will have rashes, different type of rashes. And then they can have hand and feet swelling, and not to forget also the lips might be swollen, and they might have strawberry tongue. And then the test, the D-dimer, ferritin, CRP, neutrophil will be high, albumin low, and then lymphopenia is there, and abnormal fibrinogen because they are predisposed to DIC also. And the differential diagnosis will be, because they will share the features with the other syndromes, we have to consider them, like the Kawasaki disease, the toxic shock syndrome, sepsis in general can present also with the same, and then macrophage activation syndrome. Then imaging, not to forget that you have to do ECG myocarditis, valvulitis, pericardial effusions, coronary artery dilatation might be evident. And then when you do the X-ray, you will see patchy symmetrical infiltrates plus minus pleural effusions. Abdominal ultrasound, you can have the, if it is indicated, colitis, ileitis, lymphadenopathy, ascites, hepatosplenomegaly. And if you went for the CT chest also, if indicated, you might demonstrate coronary artery abnormalities if the CT with contrast. Monitoring, because the disease might evolve very fast and the child might deteriorate, it is very crucial. Once you have an index of suspicion of this disease modality, you have to monitor your patient closely for signs of respiratory or cardiovascular deterioration and worsening of the ongoing inflammation. If there is worsening of fever, cardiorespiratory deterioration, worsening GI symptoms, increasing hepatosplenomegaly, lymphadenopathy, rashes, worsening neurological symptoms, coming down level of consciousness. Also, you have to check for the serial labs. If there is signs of increasing inflammation, falling blood counts, rising ferritin further, unexpectedly high or low ASR, a rising fibrinogen or new onset low fibrinogen, and rising transaminases or D-dimer, or you have low serum sodium with worsening renal function. And then you have to seek ongoing advice from a specialist center. And not to forget that this disease entity should be managed by multidisciplinary team, including that a rheumatologist should be there, intensivist should be there, and hematologist also, and cardiologist, because also the myocarditis might be very severe. The child might need anatropes management. Children described in the Raffin study were treated with IVIG, and most were treated with aspirin, as a child with Kawasaki disease would be. But this will be variable according to the condition of the patient. In addition, all children receive broad-spectrum antibiotic. The role of other immunomodulatory therapy is uncertain at this time. All children should be treated as suspected COVID, meaning that your precautions should be done for the COVID-19, and refer to your local policy on management of COVID-19 suspected, as well as empiric or targeted antimicrobial guidelines. For mild to moderate disease, supportive care only is recommended. If clinically deteriorating or severe disease, you have to transfer the patient to the intensive care unit. And antiviral therapy should only be given in context of the clinical trial if available. Because as we know that till now, fortunately, the COVID-19 infection in the pediatric population is milder than the adult. And then in the management plans, then you don't include them routinely with the antiviral therapy unless your hospital or your center is part of the a clinical trial, then you can adopt. And then here this is part of the Royal College guidelines for the management. If they have the serious response, commonly they might present with a vasodilated warm shock or vasoplegia, refractory to fluid boluses, and they might have cardiac dysfunction, and the cardiac output can be sensitive to inotropes or fluids. So you have to be very cautious in titrating your fluid boluses and the inotropic support. And especially when you are transferring the patient from one area to another area, for example, from the ward to the PICU, you have to be very cautious because your patient might deteriorate at any moment very fast. And then the inotropes, common advice referring hospital to begin peripheral inotropes till you have the central line. So peripheral inotrope, you can start dopamine or epi. And then nor-epi vasopressin may be needed. And then if evidence of cardiac dysfunction, then you can consider milrinone, levosimendan, other supplements. Coronary artery aneurysm seen in some patients. Then in the echo, maybe you will see the coronary artery brightness and appears a common feature. Although we know that for the typical Kawasaki syndrome, only like around 20% they might have a coronary artery abnormalities, including aneurysm. Extracorporeal life support, a few children, around 3, required ECMO. Since progression of cardiac dysfunction can be rapid and unpredictable, early transfer to an ECMO center should be considered. Refractory arrhythmias, shock are indication for veno-arterial ECMO. Caution, many patients are prothrombotic. Although they mentioned that the thrombosis events in the pediatric population less common than the adult. And the renal replacement therapy not required in majority of patients. For the mechanical ventilation, around 60% of patients might require, usually for support of cardiac output or to enable optimum condition for line insertions. But some patients, they can do very well with the high flow nasal cannula or non-invasive ventilations. For the antibiotics and infection control, SARS real-time PCR testing, inconsistent, serology commonly positive if done. So it depends on the serology more. Full PPE advice pending the results because you will treat the patient as we agreed as a case of COVID-19. Although evidence of viral bacterial co-infections is rare, antibiotic as per local guidelines should be started at presentations. For the immune modulatory anticoagulation considerations, risk of venous thrombosis, especially large vessels. So approach to anticoagulation, low molecular weight, heparin, high dose of aspirin is very variable. It is variable from one center to another. Discuss with your local hematology team. And then approach to immune modulation such as IVIG, steroids, anakinra, tocilizumab, very variable. Also discuss with the local multidisciplinary team. And me, I attended one webinar early June, and they, in their presentation in this same syndrome, they mentioned that they treated around 20 plus cases presenting with severe myocarditis. They were treated successfully with IVIG, and they used the steroid as the second line, and the anakinra for those who are having high interleukin-1, and tocilizumab for those who are having high interleukin-6. But still, we have limited data to support the use of these modalities. The prognosis, the length of stay in the PICU is generally short, 3 to 4 days, although it is sometimes severe disease and the patient might stay longer. And the great majority of patients survive. And I forget to mention that among the previous table, the records of the patient collected from different parts of the world, the total number was 300 plus, and the case fatalities were five deaths. So the majority of patients survive. So in conclusion, we have a new hyperinflammation syndrome which emerged in children. It seems to be temporarily associated with COVID-19 pandemic. The majority test positive for the previous SARS-CoV-2 infection. There is an overlap with some features of Kawasaki disease and other hyperinflammatory syndromes, often with shock and with little to no respiratory compromise. The mechanism of the illness is unknown, but research has already begun, and there are no specific management options at present, though early discussion with the pediatric subspecialties, especially infection control, rheumatology, cardiology, is important. With this slide, we conclude our presentation. I hope it was useful for you. And then we can open the floor for the questions. These are the references from where I collected the data I presented.